uh, somebody who has done some fantastic contributions on the chat in previous webinars, and the feedback that we got from you was you really wanted to hear more about this. In particular, some of the concepts behind AFOs and gait analysis, and how these techniques can be used to help patients with cerebral palsy. So this seemed like the golden opportunity to give a bit more chance to delve into this. So George has very kindly agreed to join us as a guest speaker. So George, we're really grateful to you. So I'm going to kick off and then hand the baton on to George, and he's going to tell you a bit more about orthotics with some case studies, and hopefully we can pick his brains about the details about how to use these kind of techniques. All right, so here's the plan. Basically, two sides to my talk. I'm going to talk a little bit about the 3 common foot deformities in cerebral palsy, a little bit about what the principles are for us surgeons in terms of dealing with them, but then specifically about referrals, criteria for referring, and what I've called the 4 commandments. That's more for us as surgeons, what we have to think about when we're giving surgical treatment for these foot problems. And of course, dealing with foot problems are often part of multi-level surgery, single event multi-level surgery. So I want to spend the second half of the talk thinking about that. Again, it's mainly to do with referral criteria. Who's going to benefit? What can we tell the patients in terms of the benefits that we might give them from such treatment? And then at the end, introduce maybe some slightly different concepts about what the role of orthopedic surgery might be. So let's get started. So why would you consider sending a patient to an orthopedic surgeon, an ambulant CP patient who has a foot problem? I think there's probably one of 4 reasons. Either because there is a clear evidence that their foot and ankle deformity is disturbing gait. And remember, we talked in the gait analysis webinar about Jacqueline Perry and the determinants of gait. So foot position has got a big part to play in all of these important aspects of efficient gait. So it might be that it's clear that the foot and ankle is what's causing the problem. Probably more common than that is that you've appreciated that this is causing a problem, but that you've controlled it up to a certain point in the orthotic, because that will often be the first thing that you will reach for. But you have a patient who you're now struggling to control this foot problem in the orthotic. For example, if the deformity is now becoming fixed. So that might be a reason for referring on for a surgical opinion. Pain, well, that's an obvious one, particularly coming from deformity, particularly coming from pressure areas within an orthotic. And then there might be cosmesis, which I don't think we should necessarily dismiss as being a less important thing. I'm thinking particularly of adolescent kids, particularly hemiplegic kids, who, in my experience anyway, derive an awful lot of benefit from dealing with foot and ankle deformity. To them, this is a really important part of their gait. And it's one of the things that Jacqueline Perry mentioned as one of the important factors of good gait was cosmesis. So it's probably going to be one of these 4 things. So when thinking about what sort of foot problem you would want to refer on to a surgeon, I think if you've not read the review article, it's worth going to look at that, because Freeman Miller makes the point that these foot deformities, particularly in young children with cerebral palsy, and particularly those with bilateral cerebral palsy, can behave in a rather unpredictable way. And it isn't really until they get to the age of about 6 or 8 that we can make a prediction about what is actually going to happen. So it's likely, and correct me if I'm wrong, but it's likely that you're more likely to be referring patients with cerebral palsy at any rate once they're older than, say, 7, 8 years of age, just because of this unpredictability. So what do we understand about the natural history of these 3 foot problems that dominate cerebral palsy? So let's talk about equinus, first of all. This is probably the commonest problem that we're going to face. Essentially, before the age of 6, it is quite common for children to walk up on their toes, those that have cerebral palsy. But some of these will resolve, and of those that persist, there seems to be a difference. Patients with unilateral cerebral palsy, hemiplegia, seem to have contractures of both gastrocnemius and soleus, whereas the patients with bilateral cerebral palsy as with many of their biarticular muscles, it's the gastrocnemius which seems to be most affected. And this makes a difference to us as surgeons because we have different surgical techniques to deal with both of those problems. So below the age of, say, 7 years, it can be quite difficult to know whether this equinus is actually going to resolve by itself. So this is something that you need to think about if we're thinking who to refer on for a surgical opinion. What about the problem of varus, which, of course, is the second common problem? It's not simple as varus, of course. We'll come on to that in a moment, but that's what people commonly call it. In these patients, there's a difference between the unilateral cerebral palsy and the bilateral cerebral palsy patients. So the unilateral patients, once they have varus, it tends to persist. And so those might be patients you're more likely to refer perhaps earlier. In the bilateral patients, presenting with varus is less common, but it is not uncommon for those then to change and move to a valgus position. So this is what I mean about the unpredictability of the natural history. So, of course, the other difficulty can be in a very young child. It can be hard to know whether this is a unilateral or a bilateral case. So varus in a young child can be something that is quite difficult to call, really. And then there's the planovalgus deformity, the third of the big three deformities that children with cerebral palsy have. Again, here, the natural history is actually quite complicated. So this is a more common deformity in kids with bilateral cerebral palsy, in which it often presents in young children, then goes through a window at which it is far less obvious, only to recur in older children. This is not universal, but this is not an uncommon natural history. In contrast, in the unilateral patients who have planovalgus deformities, which is not so common, these can either resolve to neutral or actually go the other way to varus. So complicated natural history, but hopefully this gives you some sort of framework to think about when thinking which sort of patients might you want to refer on for a surgical opinion. So once they arrive in our clinic, what are our principles? What are the tools in the toolbox, and what sort of general principles do we use when thinking about what sort of treatment we can give? Well, essentially, there are a number of important principles for dealing with any neurological foot. Number one, we want to realign joints, and where joints are not congruent, we want to make them so. Number two, if there have been secondary deformities created as a consequence of the underlying neurological disease, then we're going to want to think about correcting those also, be that a joint deformity or a bony one. Torsion would be a good example. Third important principle, particularly for neurological conditions, we want to avoid recurrence if we can. So this involves some sort of thought about rebalancing muscles in order to try and keep the correction that we have achieved. And the final principle is, if at all possible, we want to avoid arthrodesis. We're much better off with a flexible foot than a stiff one, even if anatomically the stiff foot looks more normal. This is one of the lessons Ponseti taught us, actually. Also, arthrodesis, particularly triple arthrodesis, can adversely affect the growth of the foot, and we don't want to cause problems with that if at all possible. So what I call the 4 commandments, these are commandments for us surgeons. Number one, tendon transfer. It's pointless transferring a tendon unless the job that it's supposed to do can work on a deformity that is correctable. So the deformity that you're trying to correct with a tendon transfer either has to be correctable or you have to make it correctable, which could be, for example, using serial casting, or it could be by some sort of surgical release. But as a general rule, tendon transfer on a deformity that is not correctable is doomed to failure. You cannot expect the tendon to do the job for you. Second commandment for us, we must try and avoid overcorrection and causing another deformity which is even worse than the first. And I'll give you a couple of examples in a second. We must not compromise growth. I mentioned about triple arthrodesis being a prime candidate for doing that. And finally, in cerebral palsy, we must try and avoid prolonged non-weight bearing because these kids are already weak and they're only going to get weaker after surgery. So these are the kind of things that we try and keep in mind, both the 4 principles and the 4 commandments. So let's put this into action. First of all, thinking about equinus. So for equinus, we have a lot of surgical techniques we can use. And you can see as we go from the left-hand side of the screen to the right, we have surgical techniques which go from proximal to distal. And these have certain advantages. If you look in zone 1, you can see that both of those procedures, and me personally, I'm a fan of the Strayer procedure. This allows us to be very precise. We can deal surgically both with the gastrocnemius contracture and leave the soleus alone, which is a big advantage in bilateral conditions. Or we can address both of those if we think both are contracted, for example, in a unilateral cerebral palsy patient. As you go down the zones, as you go towards the right-hand side of the screen, the surgery is effective for dealing with equinus, but it becomes less and less specific until you come to zone 3, where we're doing Achilles tendon lengthening by percutaneous means. And these will tend to lengthen both the gastrocnemius and the soleus, which you may or may not want to do, depending on whether this is a unilateral or a bilateral case. So we have a lot of options here for dealing with equinus, all of which have their pros and cons. So one of the advantages, the more distal you go, the better correction you're going to get. The magnitude of the deformity that you can correct becomes better. So that might be a reason for choosing a more distal correction. On the other hand, there is that risk of overcorrection the more distal you go. Or look at it another way, if your glass is half empty rather than half full, you could say that the more proximal you go, the higher the chance of recurrence. So this is something in our minds as surgeons that we have to decide when dealing with equinus. That's a problem that we have to wrestle with. Just while we're on the subject of Achilles tendon lengthening, I don't know, Michalis might have his views on this, but I have found it's quite uncommon in cerebral palsy to do an open Z lengthening of the Achilles tendon. We tend to do it percutaneously by one of the techniques you see in zone 3 here. There seems to be something about preserving the tendon sheath which avoids that problem of overcorrection that we are worried about. So maybe for severe deformities, for revision surgery, you might do an open Z lengthening of an Achilles tendon, but it's becoming increasingly rare, particularly in my practice. Incidentally, releasing the capsules, the posterior capsule of the ankle and the subtalar joint, pretty unusual in cerebral palsy, much more common in other conditions, club foot being a good example. In terms of the rehabilitation, for me, this is an operation we really want patients up and walking on day 1. So I don't worry too much about the fact that the Achilles tendon has been lengthened. I'm not worried about over lengthening it. These are patients who I get up and walking straight away. So any type of cast immobilization is going to make patients weaker, but if we can mitigate that, then I do it. And for me, the casting is for 4 weeks if we do a zone 1 operation. For a zone 3 operation, it's 6 weeks. I have absolutely no evidence why I do that. I guess I'm just feeling that a more distal tendon release is likely to take longer to heal. So here's the big problem. Here's one of the big no-nos. Thou shalt not overcorrect and cause another deformity. So here's the big no-no for bilateral cerebral palsy. Thou shalt not, it is said, perform bilateral Achilles tendon lengthening. This has been one of our crimes in the past. Why? Because the Achilles tendon and the plantar flexor muscles, so-called, remember, have an important job in concentric contraction, in powering you forward, but they have an even bigger role in eccentric contraction, in putting the brakes on the second rocker. So the second rocker, as your body is flying forward, as your tibia is flying forward in the second rocker, it's largely momentum that is taking that forward, and your plantar flexors are the ones putting the brakes on. If we have weakened that mechanism by lengthening Achilles tendon, then crouch is what we get. And crouch is something, as a general rule, we really want to avoid. It can be part of the natural history of cerebral palsy, but unfortunately, it can also be iatrogenic, hopefully less common than it used to be, but it's difficult to treat, so we try and avoid it. And as a general rule, we would much rather live with a bit of persistent or recurrent equinus than deal with a patient in crouch. So varus, I put it in inverted commas. This is the second deformity. It's not really varus. Varus is what you see in the hindfoot. But you will remember, if you've been on the previous courses, the foundation and the advanced course, where we talked here a little bit about how these foot deformities arise. And here's a way of looking at it. The talus is what it's all about. The talus sits under the tibial plafond and it has no muscle attachments at all. So everything moves around the talus. where that yellow dot is. So those of you who do Ponseti manipulations will be familiar with this idea. Think of the foot as being what Ponseti people talk about, the calcaneopedis block. It's one block of bone and joint that moves around the talus, rotates around the talus. So if you have varus, it's actually a combination of movements. The calcaneopedis block rotates around the talus into inversion, as you see, and varus is what you see from the back. What you see from the front is that the forefoot is supinated. And actually, because of the kinematics of the subtalar joint, it's actually down as well. So there's a little bit of equinus as well that's coming from the subtalar joint and not from the ankle above it. So we call it varus, but actually it's a bit more of a complicated deformity than that. So often the midfoot can be involved with a cavus deformity, and often there can be true ankle equinus as well. So these three exist together. This is a more common problem in unilateral cerebral palsy, and at least early on, it's passively correctable, and that passive correctability can last for quite some time. You remember we talked about the natural history. Varus in a unilateral patient, it tends to persist. But the good news is it often remains flexible for a considerable period of time. What is the culprit? Well, the books will tell you that you have to try and work out if this is a problem of varus in the stance phase, in which case it's a stance muscle, which is responsible, tibialis posterior, or is this a problem where the heel is going to varus in the swing phase, in which case you're going to blame tibialis anterior, which is primarily a swing phase muscle. That, as usual, with many things in cerebral palsy, is great in theory, but in practice, it's quite difficult to tell. And there are various tests to try and work out which is the responsible tendon. Ultimately, EMG and gait analysis might be useful to you, but the reality is operations for both of these tendons, the tibialis posterior and the tibialis anterior, both have a good track record in correcting this problem. And why? Because we're obeying two of those rules about what to do with foot deformity. We can realign the joints, but we're rebalancing muscles to prevent recurrence. So essentially, we have the principle of tendon transfer. It really comes into its own when we're dealing with varus problems. We tend to do in cerebral palsy slightly different to what we do in the club foot. In the club foot cases, we tend to transfer the whole tendon, particularly the tibialis anterior. In the cerebral palsy cases, we tend to do a split transfer because the experience has taught us that overcorrection is a real problem if you transfer the whole tendon. So we like to kind of hedge our bets and just transfer half the tendon, as you see in these pictures, both for the tibialis anterior and for the tibialis posterior. And these, when combined with other soft tissue procedures like plantar fascia release or Achilles tendon lengthening in combination, can be a really, really powerful way, an effective way, and long-term way of correcting these varus problems. Post-op, well, it kind of depends what you've done. We always worry as surgeons if we've transferred tendons about the fixation. So if your surgeon is frustrating you by insisting on having the patient non-weight bearing, it could be because he or she is not convinced about the ability of their hardware to fix the tendon into the new drill hole that they have created in a bone. We've got lots of ways of doing it, but we always worry about that tendon pulling out. So you may find, in contrast to pure equinus corrections, you may have to adjust a little bit what you do in terms of protecting weight bearing, possibly using an orthosis post-operatively. And then there's the planar valgus deformity, which is the most complicated of the three and the one which causes the most debate. So this, again, is a rotation around the talus, but this time into eversion. So the calcaneopedis block rotates into eversion. You will see valgus at the heel. You'll see an uncovered talar head. And you would expect to see a pronated forefoot, as you see in this picture, wouldn't you? Well, yeah, you would, except the weird thing is, if you then correct the heel back to neutral, you see that the forefoot is not pronated at all. It is supinated, the opposite of what you would expect. Now, why is that? Well, again, we talked about this in the foundation course and in the advanced course. This is because the foot has now created a secondary compensatory deformity to that pronation. the foot has actually supinated in order to bring it neutral again, which you then uncover when you push the heel back to neutral. So we have now got two deformities in opposite directions, what Michaelis referred to as the wrung out like a towel principle. So this is now getting quite complicated. These are patients then who have not just plano valgus, but equino-plano valgus. The reason being that by everting your foot, you can gain some dorsiflexion at the subtalar joint. So if you have equinus, this is quite a useful way to try and get your foot flat to the ground. The price is, of course, that the foot comes out, and this is why patients out-toe and have an exposed talar head. But you could look at it as being a good compensation for equinus. Anyway, these are typically in bilateral cerebral palsy patients. And in contrast to the varus problem that I just mentioned, the correctability can be rather variable. Sometimes they're partially correctable, and sometimes they're completely fixed. We've got lots of surgical options for dealing with this, which I think are a lot more fun for us than they are for the surgeons. Than they are for the patients. So one technique, just to run you through them quickly, lateral column lengthening involves, exactly as it says, lengthening the lateral side of the foot by a calcaneal osteotomy to essentially cover the talar head again, which is a really elegant way of dealing with the primary problem. You may also come across calcaneal osteotomy, which is technically simpler to do, but if you think about it, it's not really addressing all of the problems. It's certainly not addressing the uncovered talar head. What you're really doing is introducing another deformity, say, for the first. So biomaking, it's not so ideal, but it does have the advantage of being quick, and probably you can weight bear patients afterwards with this. Triple arthrodesis, we don't use so often, but for a rigid deformity, that might be your only option. Has to be in older patients or you'll affect growth. So all of these are bony operations. They all require internal fixation. So they're all going to need casting, and they might need limited weight bearing as well, with the possible exception of calcaneal osteotomy. So you see how as the deformities get more and more complicated, so the rehab is going to get more complicated. So that's something that we're going to have to deal with, and something that you and the surgeon can liaise with in terms of how you're going to move forward with that. So just to summarize the foot deformities so far, because that's all I've got to say about those. There are three major deformities, and they all vary in their natural history and their complexity. They're all rather unpredictable until the age of about 6 to 8. And we as surgeons, our problem is not the operative techniques for dealing with those. We have good operative techniques. The problem for us is knowing which are the right patients to operate on. So what is the indication for surgery? What is it likely to bring to the patient? And that is why it is so important that we work together, physios and surgeons as a team. Because I can tell you, when we see patients in clinic, we maybe see them for 20 minutes. We've never seen them before. We have none of the background history about what the goals are, what the functional problems are. So it's really important before embarking on major foot surgery that we liaise, because for us, the challenge is the indication. It's not that what shall we do, it's should we do it? So I'm going to move on to sort of engulf foot surgery as part of surgery in general for ambulant children with cerebral palsy. So here's the challenging case that I sent you. I'm going to play the video again, and we're going to run a poll in just a second. So this is this child walking, 15-year-old girl, not my patient actually. She belongs to somebody else. She scored herself as GMFCS 2. I think she's being a little optimistic. And I've slowed the gait down so you can see it. She actually walks with a much quicker cadence than this. I'll play it for you again. So mild fixed flexion deformities of her knee, well, say mild, 10 degrees plus on both sides, and fixed flexion deformities of her hips, pain in her knees, pain in her back. She volunteers, she's got problem with weakness and exercise tolerance, and she wants to walk straighter. So, I have some questions for you. Imogen and Ruth, can we share the poll, please? Thanks very much. So if you can give me your answers to these questions about this particular case, because I'm really curious to see what you make of it. And then we'll go through some more evidence and see if your answers tie up with what the published evidence is. And hopefully we'll get some chance to discuss it at the end. Okay, great. Can we end the poll there, do you think?
Yeah, not a problem.
Thanks very much. All right, great. So it's interesting. You are agreed on the first two, really, the majority of you anyway. You think there's going to be a gradual deterioration in this patient's walking ability. She's got crouch, right? So that would seem to be a pretty commonly held view. Referring to a surgeon, again, sort of same proportion of you, damn nearly, think they should come to a surgeon. So you think that's a problem for us to sort out. When it comes to the next few questions, there's some interesting splits. So we're not quite sure whether this is going to improve her or just stop her getting worse. And there's a few of you who think that it will either do nothing or make it worse. And similarly, like the 60-40 split here between those of you who think that it's going to improve motor function. But the majority think it will. All right, great. So my plan is to go through some of the theoretical answers to these questions, and then afterwards, if there's time, we'll deal with this particular case. So we've talked about it before, we are slightly anxious in the surgical world that there is a feeling that, you know, we are the devil incarnate when it comes to dealing with cerebral palsy patients. And this is probably because of how we have behaved in the past, frankly. It's interesting. My understanding from the literature is that it used to be the norm to do staged operations on children with cerebral palsy because it was felt that the results were so unpredictable that you had to really see the result of one operation before you planned the next. I heard a very interesting talk from one of the Gillette surgeons, one of the pioneers of gait analysis, who complained particularly about the British attitude, which was, what's the problem? You know, you just cut the tight bits in cerebral palsy. You know, why are you making it so complicated? Well, I think we all understand that pathological gait is a lot more complicated than that. So there were some pretty unpleasant results from that sort of approach. Crouch, patients with very stiff knees who found difficulty sitting, never mind walking. And then there was a certain sort of shrug of the shoulders that, well, it's cerebral palsy. What do you expect? You know, blame the patient or blame the physio for not getting the result that was expected. And the picture at the bottom here, of course, refers to this so-called birthday syndrome, where these poor patients had operation after operation, rehab after rehab. Now, single event multi-level surgery, doing all the surgery together, which was first reported in the 1980s, around the sort of time that gait analysis was taking hold, has really become, at least in my experience, the gold standard. I don't think anybody disputes that this is the right way forward with these patients. If you're going to do surgery, you should do it all together. There's a question about timing, which we'll come to. But does it work? Well, there's heaps of evidence about single event multi-level surgery, but nearly all of it is cohort studies with no controls. And what do we know about level 4 studies? It tends to exaggerate the effect. So we really need to delve into some more high quality evidence if we really want to understand what effect we're having with orthopedic surgery on these children. So why might you submit a child, an ambulant child with cerebral palsy for surgery? Would it be because you want to make them walk better, because the walking looks better? This is kind of relevant to the case I showed you. Is it because you feel that surgery is necessary because you know they're going to get worse and you want to stop that? or because you can tell the patient, well, if we do this, you'll be able to do more in terms of gross motor function. And when you're going to do it, are you going to do surgery when all else has failed? Or, and this might be a new concept, should you do it early? Are there some advantages of doing early surgery to try and improve outcome for the patient? It would be really nice to know the answer to these questions, but these are unanswered questions in the literature. I don't know the answer to these. I think maybe you don't know the answer to these. So we have to work on a case-by-case basis until we get better at the published literature. So these questions are all important questions, but I'm afraid there is just no clear answers to most of them. And this is another reason why the liaison between physios and orthopedic surgeons is so important in ambulant cerebral palsy. Tools available to us, standard orthopedic tools. Tendon lengthening, we've talked about. Tendon transfer seems to be more popular in the upper limb. There was a vogue for rectus transfer for stiff knee gait, but again, it's one of those operations that, perhaps I'm being a little harsh, but great in theory, great in the gait lab, but the results of surgery are rather disappointing. So tendon transfers do have their place, but are less common. Osteotomies, both angular and rotational, arthrodesis, all of these are possibilities for us. But bear in mind also guided growth. So guided growth is a really useful part of single event multi-level surgery. It's normally surgery, minimally invasive surgery, I guess you could call it, for angular deformities, for correcting varus and valgus. But we find it really useful for correcting knee flexion deformities, as you see here, by positioning the 8 plate in the anterior part of the distal femur. So it does this by essentially slowing up growth at the front of the growth plate whilst allowing it to continue at the back. So this is really, really useful for a flexion contracture of the knee, minimally invasive. And the correction rate is less than 1 degree a month though, so it's slow. But here's the big advantage. We've just seen a case with crouch gait. We know that knee flexion deformity can be a big problem for these patients' kinematics. So here's the alternative. So this is a patient after skeletal maturity who's had a distal femoral extension osteotomy. And can you see how the patella alta has also been changed? So it's looking a lot better in the post-op picture here. But what this belies is the surgery that has gone on here. Essentially, I've detached the whole of the extensor mechanism and reattached it more distally and put a large cerclage tape to protect the repair that I've done. So it doesn't look much on the X-ray, but in terms of rehab, to detach a cerebral palsy patient's extensor mechanism and get it better, this is a big job for you guys. So we're very keen on guided growth. So if there's one take-home message, it is that patients with crouch, we much rather see them early while they're skeletally mature, because this is much better for us in terms of our surgical techniques, much better from the rehab point of view. What about the timing of surgery? So when should you do this? Well, there was a systematic review produced by the Oxford Group in 2018 about this. They looked at all the different possible predictors of multi-level surgery. So GMFCS level, gender, topographical distribution, and so on. And they found that age was, the age of 10 to 12 was they got the best results. And there's probably 2 reasons for this. Number one, as you all know, regardless of GMFCS level, gross motor function improves with age, but then plateaus. Usually sort of by the age of 9, it's plateaued. So gait has stabilized. So not a lot of point in doing surgery earlier than that, because things are likely to spontaneously improve anyway. And the Oxford Group very helpfully said they thought the ideal candidate for multi-level surgery, a child aged 10 to 12, GMFCS level 2, because these had the better outcome than the 3s, obviously with a poor preoperative gait profile score. So, well, obviously, you know, a patient with whose gait was severely pathological. They also mentioned
30 minutes, just so you know.
Thanks so much, Imogen. So the other important thing was why 10 to 12, because these patients are largely into their pubertal or pre-pubertal growth spurt, which there is some evidence that's when contractures get worse. So 10 to 12 is that kind of sweet spot where patients have already gone to the stage where they're plateauing and have gone through the growth spurt. And that's the traditional answer to the timing of surgery. It should be relatively late. So the Oxford group also mentioned that you should consider surgery when there is no further improvement with non-operative measures, by which they meant Botox and splintage and physiotherapy programs of various types. So for them, it was quite clear. Surgery is a treatment of last resort. And that's really largely the way SEMWELS is considered. But I said the Oxford group said the best results. Well, what are the best results exactly? I said there are lots of level 4 evidence showing that orthopedic surgery is effective at changing gait. But what about level 1 and level 2 evidence? So here we're looking at systematic reviews, of which there are lots actually, and I'm going to send you one after this webinar. But the problem is there is just one randomized controlled trial of orthopedic surgery as a single event surgery versus controls. If you compare that with selective dorsal rhizotomy, it's not even close. So no wonder we are struggling a little bit with our evidence. But this is the evidence we have. So what does it tell us? So here's the basic conclusions. Perhaps unsurprisingly, single event, multi-level orthopedic surgery can improve your gait in terms of scores, the quality of your gait. So often scored through a gait lab, and also passive range of movement. This is obviously a good thing. But in terms of gross motor function, the evidence for orthopedic surgery improving that, very limited. In fact, in the pooled data in the 2019 study, which I will send you, they say that there is in fact no evidence that orthopedic surgery can improve gross motor function, which was a lesson to me. And I've got to say, I find slightly embarrassing. As for improvement in participation, which is something Anita mentioned last week very passionately, or quality of life, of these 75 studies, there were only 3 which looked at participation and only 2 which looked at quality of life. And though those studies both showed improvements in both of those, that's hardly good, solid evidence. So there's a lot of work to be done there. As for parental satisfaction, again, it was overall parents do seem to be satisfied with the result, but big variability. And I suppose you might argue that the same goes for the results on improvement in gross motor function. We're talking about a very heterogeneous group. So a patient with bilateral problems and crouch gait might do very differently from a patient with bilateral problems and jump gait, might do very differently from a patient with hemiplegia. So it's one of the problems of pooling your data. And in the interests of being thorough, because we talked in the first webinar to be not about evidence-based, this is where orthopedic surgery sits, SEMWELS. So small evidence base, it's above the worth it line, but we're not getting into the definitely do it. So the evidence for the benefit of single event multi-level surgery is actually perhaps not as robust as you might have thought. So we do have, alhamdulillah, as they say in this part of the world, we have one randomized control study from the Melbourne group. Where else? So this was a really useful study. They looked at 2 cohorts of bilateral cerebral palsy patients. They did single event multi-level surgery on one half of the cohort, and the other half, they delayed that surgery by 1 year. So that gave them 1 year of follow-up to compare the 2. So at 12 months, what did we find? Well, perhaps as the systematic reviews have told us, we have improvements in their gait, but no improvements in gross motor function, quality of life, or functional mobility scores either. When we go to 24 months, however, we compared to the pre-op, because remember the second cohort, the controls have now undergone surgery, but at 24 months, there is an improvement in gross motor function with surgery, and also improvements in some of the other functional scores as well, compared to pre-op. So some evidence here, 4.9% increase, that's reached statistical significance. Clinical significance, I don't know. What do you think? To me, that doesn't seem like a huge increase, but maybe that will mean a lot to a patient. They then followed up this cohort 5 years later, and they found that that this improvement in the motor function of 4.9% had dropped a little bit, but was still definitely there compared to pre-op, but only 3.3% increase. That's clinically and statistically significant according to this study. But what do you make of that? To me, that doesn't seem like a very big return on what was a very big investment in and rehabilitation load for this patient to go through. For us to see such small increases after 24 months, I don't know. So just to finish off, here's a different way of looking at orthopedic surgery, just to introduce you to some concepts that are sort of buzzing around the orthopedic world and the rehab world at the moment. So this picture gives you an idea of where we're going to go. If you look at this picture, you'll see the face of a woman, but what do you see? Do you see a old woman in profile, or do you see a young woman looking away from you? So there's two ways of looking at this picture. So I want to talk about two ways of looking at orthopedic surgery and two ways that it might help these patients. So here's the traditional model. We know, do we not, that these patients start off with a dynamic deformity which becomes fixed. And the cause of the fixed deformity is restricted muscle growth. And the cause of that restricted muscle growth is spasticity. And this is the rationale for attacking spasticity with anti-spasticity agents, of which Botox is a good example. And muscle growth, well, if the muscles won't grow, you better stretch them and make sure that you regain that length. And when all else fails, we've got good old orthopedic surgery to get us out of trouble. Everybody happy? Okay, this is the traditional model. But there's some problems. So if we have learned quite a bit over the last 4 weeks about cerebral palsy, and one of the things is the complexity of what these ambulant children are facing. So they're not just facing a problem with muscle growth and tone. They're facing a problem that they can't actually tell which muscles to move. And when they do tell those muscles to move, they often fire a whole lot of other inappropriate muscles as well. But there's a massive problem with muscle growth and muscle strength. So all of these three things together mean that you have a limited ability to rotate a joint, which means that you fatigue easily and you can't generate force. So the muscle growth is the important thing. And why would the muscle be growing abnormally? Well, two reasons. One, because it's abnormally innervated. And secondly, because it's abnormally loaded. So muscle is a superbly plastic tissue which responds to load. If that were not the case, Fitness First would not be making such good business. So muscle responds to load, we know that. And we know that muscle strength is really important in kids in cerebral palsy because it is correlated in a direct way with gross motor function, as this prize-winning paper demonstrated in 2008. Similarly, we know as you go through the GMFCS levels, patients become weaker and weaker, as shown in this paper. So weakness and strength, they have a really important role to play in function. So perhaps we should be concentrating on this. So here's where the surgery comes in, because generally it is thought that surgery is a bad thing to do to muscles. So this paper from Nicola Fry and colleagues really illustrates the point. If you take typically developing kids and compare them here with kids with cerebral palsy, the lighter color, and you measure the volume of their medial gastrocnemius, it's less than half the volume of what it should be. These are small muscles. This was measured by ultrasound. Now, these patients then underwent surgery, which is generally considered a destructive thing to do to muscle. But here's the funny thing. When you look at the volume of these gastrocnemius muscles after the operation, they haven't changed. And in fact, when you follow up, they have shown a trend to increase in volume, which is perhaps rather counterintuitive. In fact, it didn't reach statistical significance. And being the pure scientists they are, the only conclusion they could draw was that surgery, calf surgery, does not cause muscle atrophy. But the implication of the results was actually maybe it's going to promote hypertrophy. So bang up to date now, 2020. Here's a very, very complicated paper from the group in Leuven. And essentially what this is looking at is the effect of doing multi-level surgery on skeletal loading. So not length of muscles, not gait parameters, but how much load goes through each of these lower limb muscles. And after orthopedic surgery, after multi-level surgery, the important thing are where these asterisks are. So these show that there is a significant decrease in abnormal loading at both the hip, the knee, and the ankle. In fact, in the case of the knee, the loading goes back to essentially normal levels. There is no statistical difference between the post-op group here and the typically developing group here. So powerful effects from orthopedic surgery, early orthopedic surgery, what's more, on joint loading. Compared to Botox, incidentally, because this was a comparative study, Botox has some effect at the ankle, but cannot affect joint contact forces, skeletal loading, essentially, elsewhere in the skeleton. So the conclusion, orthopedic surgery can alter the loading of joints. So why is this important? Well, it goes back to the idea of muscles responding to load. So here's the bad news. If you are typically developing, your muscle strength increases with age until you get to around about 20s, 30s, depending on whether you're male or female. And then, sorry to say, it's downhill all the way. The same is true for our cerebral palsy patients, but they never reach the thresholds that we do. So not surprisingly, they struggle with function and they deteriorate. So wouldn't it be nice if we can do something to push that curve up, to push their muscle strength up, in order to give them a higher point to fall down on when the inevitable deterioration comes? So we in the orthopedic surgery world are thinking about this slightly differently, as I think you are thinking differently about your physiotherapy programs. So we know that surgery can alter loading, and if loading alters muscle volume, perhaps we should be thinking more about these kind of techniques, more on strength and less on length, more on muscle plasticity and less on spasticity and capacity for growth. So just as you're thinking about strength training, so we're thinking about orthopedic surgery to try and build muscle volume. Or as one of our, Michalis and I have a colleague who has a great way with words. He thinks that we surgeons, we need to stop being carpenters and think about being gardeners. So here's the summary from these points. For foot problems, there are three major ones. They all have different natural histories. Important to bear that in mind when thinking about referring on. When they do get to us surgeons, the operations, there's not too much difficulty with that. Our problem is knowing whether the operation is the right thing to do, and that's where the teamwork is so important. What can we say about current state of single event multi-level surgery? We can say it improves gait, but that's pretty much it. I think we should try and organize our teams so that patients with crouch gait and patients with fixed equinus come to surgical attention at an early stage, if at all possible. And finally, hopefully I've introduced this concept that maybe we as orthopedic surgeons need to think differently about what it is we're bringing to the party here. We should think about what our surgery can do for patients' muscle strength and muscle volume as much as the passive things like range of movement. So that's all I have to say on this. We may have time to talk about the challenging case because I'd really like to get your views on that. But before we do that, I think it's really important that I pass the microphone across and stop sharing my screen because George is waiting in the wings, and George has some really interesting stuff to tell us, to update us and tell us about the principles and some case studies for some of the stuff that you asked us to cover in the feedback. So George, I'm going to pass on the microphone. Thanks very much for listening.
Thanks so much, Calvin. George, can you share your screen? Can I just say, I'm trying to keep the timings right. So before we go to the discussion, the case studies, we're probably going to have about 20 to 25 minutes, okay? Take your time.
Yeah, that's absolutely fine.
And it's okay if you don't cover anything. You know, this is not about covering all these amazing things that you're gonna tell us. Okay? It's just to give us an idea about all this wonderful work that you're doing with Elaine. Go for it.
Okay, right. So thank you very much, everyone. First of all, thank you all for the entire course. First of all, I found it by accident, really, and then have really enjoyed every week, really. But thank you all for asking me to join. So my name's George. I'm one of the orthotists at the London Orthotic Consultancy. I just don't really tend to see many orthotists doing these kinds of things, typically. I think mainly because there's just so few of us. So I was just trying to look up sort of the numbers. So orthotists seem to have got hard to get hold of. And the reason why I think that is because there's just too few of us around, really. So according to CSP, there's about 6,000 physios but BAPA doesn't have a true number, but there's less than 1,000. So less than 1,000 orthotists. So BAPA being our professional body. So there's about 60 physios for every orthotist on average. Probably less, really, but that's why typically there's sort of one orthotist a hospital or one orthotist a county, etc. There's just not many of us around. And then I am incredibly lucky where I am. We've got a gait lab. I work directly with Elaine, which is incredible. I never would have thought I'd been so lucky. And yeah, we do fantastic work. I've sort of learned more in the last 2 years than I had done the other 4.5, really, and including on top of my sort of degree. Right, so just moving on. So a little bit about myself. So I have been working for about 6 years now. Graduated from Salford, did placements in Wolverhampton and Charing Cross. Worked 4 years at Queen Mary's Hospital here in London, where I worked in specialist in inpatient and outpatient neuro rehabilitation, including MDT pediatric clinics, MDT adult clinics, MDT upper limb clinics. It's the only thing I really miss about not working in the NHS was how connected I was with everyone else. So I really appreciated that. But at the moment, I did a little bit of work at King's College, but at the moment I work as a private autist in LAC, London Autistic Consultancy. And yeah, I work directly with Elaine, which has been incredible. Very hard, and very, what's the word? Very steep learning curve, but very, very interesting, very, very good. So sort of first of all, we have some essential readings. So when people hopefully come back and look at the presentation, you can sort of have a look at these. Most of these are from Elaine, or all of them from Elaine, you'll probably realize, but most of our research and thinking sort of comes from Elaine, which is why most of the stuff will be referencing her opinions, her training. If anyone's done the training, if you haven't, I highly advise it. It is very interesting. It's very hard. It's a 3 days course, and I think it's all online now because she typically does it from the safety of her living room, and then with a gait lab helping her out. Right, but let's crack on. So what is OSCAR? OSCAR is just the term that we use, but basically we're thinking about it less in terms of joints and joint deformities, and we're thinking about it in terms of the kinematics of the lower limbs and how we would adjust those. So just some very general things. This is less about OSCAR and more just about robotics in general. OSCAR is just a sort of technique that we use. But I mean, these are some quite big things I haven't really thought about before I came to LAC, but being here for 2 years, I've seen quite a lot of this, sort of reducing, using it as a precise method of prescription, protecting the body from deforming forces, reducing the need for invasive surgeries and other invasive interventions. So like what Gavin was talking about earlier. And then trying to set goals using ICF charts to sort of help the patient really achieve what they want rather than just what we think is best. So we use the ICF assessment clinical forms here. And this is pretty much everything we would talk about with a patient. It's quite a long appointment typically, sort of about maybe 2 hours, sort of minimum, I would say, with the casting, gait assessment, discussion of all these things, clinical assessment. Have done it quicker, but it's been a bit of I'd probably say about 2 hours on average. So the main things we're sort of looking at are sort of the bones and segments, muscular, tendinal unit lengths, as we were talking about last week, talking about, well, not last week, week before, participation, especially in school, or standing balance are really important things to talk about. ambulation, and then obviously the environmental factors that we'd have to talk about, sort of like, are they in a specialist school? Have they got one-to-one? What have they got at home? What's their equipment, etc., etc. It's all quite a lot of stuff to think about. It's all quite a lot of stuff to talk about. So then I've got a few case studies towards the end, and people are more than happy to ask some questions about that, but I'll just try to make sure we have plenty of time at the end to discuss sort of cases. So then, okay, so why use ankle-foot orthoses? So here we have two pictures of patients on our gait lab. We sort of have one on the left, which is sort of hyperextending knee, very classic cerebral palsy presentation, and then same on the right, sort of a fixed flexion, well, not fixed flexion, but a sort of flexion crouch gait style gait that we see in typically the two main ones that we would see. But why would you use AFOs? Why would you not just use insoles? Why would you not just use big boots or something like that? I've seen some pretty, and I've heard of some pretty crazy things out there. Why don't you use carbon braces? Why don't you use CAFOs? Why don't you use larger devices? I mean, there's lots of reasons why you wouldn't, but AFOs just seem to be very elegant devices that sort of do everything that you'd want them to do. So the first thing we look at is clinical assessment. I'm not going to go too much into this. We went through quite a lot of this last week, and just in general, I imagine most people will know a lot of this. In terms of these, we look at everything. We try to take pictures, so we've got it all saved, and then we can measure them straight from the pictures. We try to take them all in, true sagittal or coronal, depending on what we're trying to measure, and then we do that very periodically, sort of every 3 months on average, just to check on how they're getting on. It depends on how old they are, what they're doing, etc., etc. Right. And then one of the main ones we talk about when we're looking at AFOs is measuring the maximum range of dorsiflexion. So one of the main things I'll go into just for this bit, just to sort of go over, while I'm sure people who have gone on Elaine's course have had this sort of hammered into them, I will sort of go over it again. Is just talking about what we describe as the ankle of the angle and the AFO, so the AAAFO, which is a very important thing to sort of determine. When I was taking my casts in the NHS, I would try to take them in as maximum dorsiflexion as possible, not past 90. And that would be to try to really, really stretch on that gastroc. And then I'd be having loads of blisters coming up, constantly having to heat out AFOs, etc. Since I've been at LAC and we've sort of gone over why do we do that? What's the reason? We don't stand with you don't stand naturally with your foot in maximum amount of dorsiflexion. So why would we ask our patients to do that? You'd be better off trying to hold their foot in a comfortable position and then trying to stretch their muscles dynamically during gaits, which is the main thing that Elaine discusses when she is going through her course. But we would take measures of this. This one would probably be one of the most important ones in terms of what we can achieve in the AFOs. And the reason why we do it like this is to try to look at the gastrocnemius muscle. So I was always taught in uni that it's a bi-jointed muscle, but it's actually a tri-jointed muscle because of the subtalar joint that is just on the other side of it. So it's very important to not only look at gastroc in terms of how much range of motion you've got in the ankle, but it's also very important to keep in mind about what position the foot's in as well. So a very common thing will be to say patient had 90 degrees of dorsiflexion in subtalar joint neutral, and that's all very well and good. But if they suddenly have 20 degrees of dorsiflexion in pronation, or if they have -5 in supination, then suddenly things start getting a bit different. If they've got loads of escape valgus, so they've got a very potentially distorted foot shape because of the excessive weight bearing, you really have to keep that in mind in terms of your AFO design. So typically what we've done is we might take ankle of the angles in sort of maximum stretch, but most of the time we sort of relax it a little bit, and that's only because of a few things really. So we've got, well, two things. So we've got we've got an AFO here. It has a little bit of a heel on it, as you can all see. And that heel is about 10 degrees plant flexed. It is pretty common design, just sort of like semi, or mostly fixed at the toes there. But why would we do this? And like I was discussing, the main two reasons would be to accommodate the range of motion and to accommodate the position of the foot. And that is a very commonly misconstrued idea, in that a patient can get to 90, so why aren't you casting him in 90? Well, yes, I might be able to do that, but if we do, they're going to have so many more issues in terms of fit of the AFO, in terms of comfort. It is much better off to try to relax the foot down a little bit and get a better quality walk than to try to force their foot into that kind of a position. There were lots of discussions in the sort of first week and then the second week about night splinting, about how you wouldn't want to overstretch a muscle during while they were sleeping, and I agree on that in the most part. But why would you want to force a child into maximum stretch when they're standing or when they're sitting in their chair or anything like that? I just can't imagine it being too comfortable generally. Right. So do we stand with ankles at 90 degrees? Do we? That's sort of like commonly believed thing back in the day. Nowadays, there's lots of research, and Elaine's doing a lot of training and a lot of awareness in the fact, but not really. And is it really important to sort of do so? Is it really that important? Like this is a very famous picture in Elaine's work of a lady walking, and then walking in high heels as well. And as you can sort of see, we have sort of heel strike, we have mid stance, and then we have terminal stance. The sort of three main aspects that you would look at in terms of a 2D video vector gait lab. And even though she is, I don't know how plantar she is, but let's say she's about 20 degrees plantar flex, she still achieves heel strike. She still achieves good kinematics at mid stance, and she still achieves good kinematics at terminal stance. So what would be the reason of trying to overstretch that muscle? If it'd be more of an idea of trying to control those kinematics, surely. And that's the main thing that Elaine talks about. So this is the original algorithm. I won't go into all of it because we would be here for a very long time. There's a reason why her course takes 3 days. But generally, I try to split it up into 3 sections. So you've got AFO orthosis design, you've got footwear and SVA design, or the shank to vertical angle design, and then you've got the footwear heel and sole design. I'll try not to go too long, because we would be here for days, really, if I was allowed to talk fully about most of these things. But the things we're sort of going to look at today are sort of more AFO design, and then sort of SVA, the sort of reason behind it. So shank to vertical angle. This is a AFO. It's at -5 inside a nice pair of Skechers trainers. So the AFO might be at -5, but the SVA is at 10 degrees. We might have to increase that a little bit more. Typically, it is about 10 to 12. On average, I think they say it's about 11.4, 11.6, but yeah, I typically find it about 11 degrees personally from what I've seen, but it just depends on age, severity, etc., etc. And the way we normally achieve that is either by the shoe themselves, some internal wedging. Sometimes we will adapt the shoes. We tend to adapt the shoes more than anything else for a few reasons. One, the AFOs take up quite a lot of space inside the shoe, and so trying to fit in extra wedges can make that just a little bit trickier. Two, we tend to have a bit more control over the sole design as well. So if you've got a patient with very poor balance, you can use these little flares so they come out on the sides. It's very beneficial to me that they're kind of in fashion at the moment. Is that you can add a lot of stability to your patient in them. And so the common thing in terms of AFOs will be that if you find a patient is, there's a few little tricks, really. They should feel, if their SVA is correct and you've got a good AFO, et cetera, you should feel, they should feel pretty comfortable when walking. It should feel pretty smooth. It should look pretty smooth. Another good one is that they should be able to squat, as long as they're flexible AFOs, should be able to squat and pick something off the ground. If they can't, you're probably under tuning it, pretty much. That's like a very easy thing to do, is just to put something on the ground and have them try to reach down and grab it. It might be a bit tricky for them, especially if they've got a lot of weakness. But if they're undertuned and their shanks are too vertical, the SVA is too low, their knees will be going into a little bit of hyperextension, a little bit of locking, and they will find that they can't get down far enough. Obviously, if it's a bit over, they will be able to do it, but they'll find the walking pattern you'll find is very disjointed, and they'll feel like they're getting tired quite easily. So it can be quite tricky trying to find that midpoint. I know that I am incredibly lucky with having a gait lab, but they're just some little sort of bits and pieces that I've sort of seen over the years in terms of trying to do it without a gait lab, essentially. Okay.
It's about 10 minutes left. Okay.
10 minutes left. Perfect. That's fine. It's just so SVA does not equal the ankle or the angle. That's something that we see all the time. Sort of people confusing the two, whether that's parents or other clinicians, not quite getting that. Yes, we've put a heel on the AFO, but that's not to do with the SVA. Or yes, we have put heel wedges inside the shoes, but that is for the SVA. They're not quite the same. Normally, a accommodation wedge for an AFO, so to try to bring it back to here, will be stuck to the AFO, and then a wedge for the SVA will be either on the bottom of the shoe or inside the shoe as an external wedge, because it very much depends on what kind of footwear you've got. So ankle of the angle, angle of the ankle, and SVA, two very separate things. So why do we sort of do this? Why do we sort of look at all this? So what we were sort of talking about before, in terms of deforming forces on the foot and trying to sort of help the AFO or help the patient. So there's a paper later on of my colleagues in Elaine where a few of our patients had their calves, the gastrocs and the soleuses measured over time. It's one of the projects Elaine's been doing for quite a long time, and found that using AFOs and no other treatments actually improved ranges quite a lot for quite a few of them, sort of going from like -20 to +5 for one or two cases. And so how do we sort of achieve that? And so if you think about it, a sort of person with a normal walking pattern, this is my director, Sam, he doesn't have a calf contracture. Why doesn't he have a calf contracture? The two main reasons is because he is constantly dynamically extending that gastroc, the gastroc being the main one, can be soleus sometimes, but most of the time it's gastroc being the tight one in terms of reasons why you start losing range of motion. And so we have two sort of points. We have maximum extension at terminal swings, just before his heel hits the ground. This is very patient dependent. It just really depends on how they are, what they're doing. And the maximum extension at terminal stance. So that red line is the ground reaction force. So that's the reaction force due to gravity, due to his weight line. I mean, in the picture on the right, he's essentially doing a lunge at that point. So he is essentially stretching his gastroc, he's stretching his hamstrings, and he's stretching his hip flexors, and all because that arrow is in the correct position. So that's all we're really trying to do, is we're just trying to align the AFOs in the most optimal angle for the patient to allow them to naturally get to this position on the right. In terms of everything else, that section, that terminal stance, knee extension, tends to be the most important. There are other important things like mid stance, heel strike tends to be a little less. because you can get away with just a stepping gait, push off, etc. All tend to be thought of very highly in terms of gait, but really terminal stance, maximum knee extension at terminal stance, not overly, not hyperextending, but getting that arrow. We typically try to aim for kneecap sort of area within the skin margins of the kneecap. So it sounds a little bit off, but the idea of that is that you will get a natural stretch on those muscles, and that is the main point of the AFOs. So a little bit about our gait lab. So we have 2D video vector gait lab, force plates. This is me walking up and down. I've not got video on it yet though, but just so you can all have a see what kind of thing we're using. We've got 2 cameras, Sagittal and Coronal, to assess in real time. And then we've used Dartfish, which was discussed the other week, typically to sort of assess the videos. So, I mean, that's it for me, really, in terms of this. I was just trying to make a sort of a shorter presentation and more about the case studies. So I don't know if there are any questions before we sort of get started on those. I haven't been looking through. So I don't know if there's anything in particular people are talking about. It looks like there's a fair bit on footwear.
I'll tell you now, George, you don't have to look, so I can pass you on some of the questions.
Yeah.
So Eleanor is asking, do you serial cast before putting AFOs?
Not typically. We have a few that we do it. So I can't serial cast, Sam can, but he does. I think he's got 2 or 3 patients on his books that maybe have serial casting. The AFOs should act like serial casts, really, that you can take off, when needed. There's a very important sort of thing when it comes to AFOs in terms of what is a prescription and what is a dose. So we see a lot of idiopathic toe walking, and that is a very common condition that we see, but what most people will say is you go into AFOs and you have to go into them all the time. That's fine, but it is more, the whole point of OSCA, the whole point of good AFOs is that it's more quality over quantity. I would rather you did an hour of good walking with perfect kinematics than you did 8 hours of bad walking with poor kinematics. It's not really going to do anything for you. But anyway, I digress. We don't typically serial cast. We might refer someone on if we think that it would be useful or it would help us out in any sort of way. So if they were really plantar flexed and we thought that something needed to be done, but we were worried about the weight of the AFOs, maybe we've got a very weak patient and we can't put that much of a heel raise on, or very often we'll have patients who are worried about cosmesis, which is very fine. We will then sort of refer on to serial casting, or I'll ask Sam to sort of step in and sort of do that for me.
Perfect. I've got two nice questions from our participants. First of all, I think Catherine has just asked, what are your indications for using or not using hinged AFOs? If you can kind of give us a bit of a summary within kind of 3-4 minutes.
Yeah, of course, because obviously I don't really talk about them that much.
Yeah.
Elaine's got a very nice algorithm for hinged splints that is very, very brutal in my opinion. I mean, it's very brutal for a reason, but it is like that they can achieve dorsiflexion, that there are no shank kinematic issues. I'm just trying to remember off the top of my head. I've got her booklet here in front of me, but I'm just trying to remember off the top of my head. There is no severe deformity of the foot, so in terms of the sort of planar valgus position, and there's no tone as well. And very, very few patients sort of fit all of those categories and would sort of get a hinge splint out at the end. Typically, most patients with cerebral palsy sort of get sort of turned away from that quite early on. Typically, what I would do is, in terms of hinge splints, I would use them in part with a more substantial splint. So we might have a pair of, well, we've got a patient later on in one of my case studies, but you might have a patient that has hinged AFOs for school because that lets them play around with their friends, and then they might have a pair of fixed AFOs for walking to the park and back, because we know that that's good walking training for them. That's good kinematic walking training. So normally it's used in parts rather than a full prescription, I would say.
Yeah, I mean, and I think that's my understanding as well, isn't it? Hinge AFOs, they're mainly for ambulant children, where to walk up the stairs or have this. So that makes a lot of sense. Now, there's a lot of talk in the chat about NHS and private. So and it's good that you have worked in the NHS before, so you can tell us in your experience. So there were some comments about how difficult it is. The cooperation, team working of orthotists with the physiotherapists together. That was the one thing. So a few comments about that. Then the other thing was about how easy it is to actually, AFO tuning and in the NHS, when it comes to time, when it comes to expertise, but also what about NHS funding? I think there were some comments there that you can either have the AFO or the SHU done. So can you tell us a bit more about that? How difficult it is on the NHS to do that kind of stuff that you're doing with Elaine in the private sector?
Yeah, I mean, in terms of my experience with doing this for the NHS, I mean, for instance, if I went back to the NHS, my work would be completely different than when I joined LSE. There are a few things that you can do to sort of make things easier and make things quicker for yourself. So things like telling them to get specific shoes. So we use two brands. Most of the time we use Hummels and we use Billy Boots, just because they are pretty easy to do. The only problem with Hummels tend to be that you have to extend the Velcro, so you have to get some longer Velcro straps attached. But you can pre-cut wedges and you can stick them in shoes. So you can have a big bag of wedges. That's what we typically do. We have we cut them by hand on the day. But what we used to do when Elaine was here, when Elaine was visiting, because it's a pretty hectic week, is we would cut wedges, put them all in a bag of varying sizes, varying heights, with sort of sticky back EVA material so that they can all stick to each other, or with some double-sided tape. So you can quite quickly make a bunch of wedges, put them in shoes and sort of walk them up and down. In terms of shoes on the NHS, I mean, when I was in Queen Mary's, it was just unheard of, really. I think one of my colleagues was able to wrangle like a handful of shoes, and that was only with a lot of emails and a lot of backwards and forths from him and his manager. It tends to be, it's really odd because it is the thing that's probably the hardest in the NHS in terms of getting shoes, getting footwear adaptions, etc. But it's probably the thing that's made my life the easiest in terms of doing my job, really. You can make shoes nice and flat and stable, so that patients feel happy. You can make them, give them large floats so that they can feel a lot more comfortable when walking, a lot more stable, like I said. And you can put the wedging on the outside rather than the inside, so you don't end up having to go to get boots or to get potentially more expensive shoes. I mean, Hummels and Billies are relatively inexpensive. Hummels, Billies more so, but that would be what I'd say, is that it's a real shame because it has made my life a lot easier in terms of doing what I need to do and doing what I need to do well.
What else could you do different? Any other hints and tips? Because there's so many. Like here is now, and then anything that you can tell us to make it easier, especially those who work in the NHS. How can they help the patients?
Yeah. So what I would say are things like making sure pre-cutting some wedges or buying some wedges pre-made will save you a lot of time, just in terms of an orthotist having to cut some out.
And where could you do that? There was a question about where could you do that, George?
So there are various companies. So if you sort of call up any sort of, that's a very good question because we make our own. There are a few companies around that will do it. So most shoe companies will also do insoles. So places like Ardens, Reeds, JSM. And so they'll probably quite happily cut up some of the EVA and grind it into wedges for you. You can just buy them on Amazon, but they're relatively expensive in that regard. You could probably get a sort of bag of 10 for the price of one sort of box of Amazon. We are currently making some for a company near us, just because they're really struggling to find some. I think the companies that they were using aren't really doing it anymore. so they're asking us if we can do it. But it's all just a bit awkward work to do. I mean, wedges would be the main thing I would talk about, or even just buying a long sheet of it. That's what we do, and then cutting up some wedges when you've got some spare time, and just getting them into shape. They won't look the prettiest, but they'll be pretty functional. They'll do exactly what you need them to do.
I think that's what matters in the end, isn't it?
Yeah. Yeah. I mean, the wedge is going to be inside the shoe. No one's going to care if they look like they've been cut up with scissors or a scalpel.
This is excellent. Now, I think there's so much going on in the chatting. What we have to do now? Why don't we do Gavin? Can you hear us?
Yeah, I can hear you. Yeah.
We still have to do your challenging case. Is that right?
Well, yeah, but I would say I vote for George's case studies myself.
They're very good, but I'll tell you what, because everybody, to keep it fair for everyone, okay, we've got time. Because everybody has been emailed the challenge case, if I ask George kindly to stop sharing for a minute, so we can go through your challenge, we can discuss your challenge case, Calvin, and then we can go back to the case study. I don't think we're going to have any volunteers, and then we have Lindsay with us who can join us for discussing George's case study. So if you can share your screen, Gavin. Gavin, can I just say, before I forget, we take like 3 minutes because there are a few questions for you as well, for your talk, before you do your challenging case. So Lindsay, for example, was asking, do orthotic shoes combination at young age prevent or reduce incidence of feet deformities?
So I'm not sure that there's any evidence that is the case. I think we're more using AFOs in order to orthotics of various types in order to control them, but we're not really expecting to do much for the natural history. That's my understanding. Is that your understanding as well?
I would agree. And there was another comment about do splints, what is it, the association between splints and muscle bulk, you know. So I did a quick search there and I couldn't find any evidence whatsoever. I think it's a difficult thing to say, but I would think it's what you said, that, you know, if you have splints, muscles will lose on bulk, on muscle volume.
Well, I don't know. I mean, I'm sure George has got some comments on this, but I think muscles tend to respond to loading. So if it all depends how your splint is, I suspect that's largely dependent on your kinematics. George, are you still live?
Yeah. So what I tend to find is a lot of patients will ask, will they get weaker if they use their splints? I tend to find it's just I don't know where it's come from. I mean, I understand the principle behind it. If you lock a joint, you know, it's going to get weaker, but it's not like the muscles are just completely switched off underneath it. They are working. They might not be working quite as hard as they were, but they will be working. Typically what I tend to find, exactly like you're saying, the load changes, and that tends to be more important. So I get I mean, I've never seen anyone get weak because of splints, as long as they're not like really painful or anything like that. But I've never really found a case of someone getting immediately weaker. I mean, maybe someone might be able to sort of expand on this, but I've never seen it personally. Typically, people in splints generally can do more in them if done right. And so what I tend to say to patients is, especially sort of like my stroke patients or such, is that, yeah, okay, in one sort of hand you might be held a bit more in the splint, and therefore your muscles might not be working quite so hard. But on the other hand, you've gone from being able to walk 10 meters to be able to walk 200 meters. So you're doing, 20 times the amount of walking that you were able to do before. So therefore, that sort of balancing act is heavily skewed in the sort of, how much can they do in the device. I mean, I've not seen much research on it sort of either way.
Right. And that's an excellent point, George. And there's no evidence for or against this, you see. So you probably need, especially when Gavin and I want to use evidence, especially for this webinar series. There's no evidence for or against, and we can only make assumptions. And maybe, it's a myth, having splints that you're going to have muscle atrophy, as you say, if you do it properly, but only if you do it properly and you use the right splints. If you increase the mobility, then maybe, that's for the benefit, and, you get a bit of hypertrophy. Gavin, post-op rehabilitation after single event multi-level surgery.
Yeah. So, one of the issues with the research is that there is often no standardization of such protocols. We don't all agree on what rehabilitation is required. And I suspect, for as many different units there are doing multi-level surgery, there are as many different protocols for doing rehabilitation. I mean, obviously the basic principles are, you want, same as I said with foot surgery, you want to get patients weight bearing as soon as possible. We need to think carefully about pain relief. We need to think carefully about, restricting splintage to what is necessary for their kinematics, but not so much that we're going to actually adversely affect their mobility. I don't know. I think that the rehabilitation program is obviously a key variable in all of this. But one thing we do know about multi-level surgery is that it takes a long time to see the benefits. The gross motor function gains that you see are not for at least a year. In fact, there's some evidence that in that year they actually get worse. So in the rehab program, you're actually fighting against that. But I'm not the right person of all the people on this webinar to be answering that question. There's at least 150 people far more experienced than me on the rehabilitation program. So let's hear.
Yeah, this is very true. I want to say two things. Something that Gina mentioned, that on your example, on the paper from Australia, that in 24 months you might not see, a lot of improvement after single event multi-level surgery. Gina made a comment that actually, if they had this growth spurt, they would deteriorate. And at least after having single event multi-level surgery, you do not have any deterioration. I think it's a very good message. I don't know if it was included in the paper, but I thought it's very good to mention. And the other thing that I want to say, we as surgeons, and I say that from my personal experience, we should try to aim for single event multi-level surgery. There is evidence for that. And then we should try also to make post-operative rehabilitation as weight bearing as we can. And I think there are meta work that they're quite recent and they allow us to do this. And we should be doing that. And I think the example of your guided growth, for the knee joints is, I certainly use them. You do that as well. We use it quite often nowadays. It's a great way how to treat crouch gait, and it allows the patient to preserve their mobility or their recovery. So I think that's an excellent message to go. Right, let's go through a challenging case so we can do some case studies with George.
Yeah, sure. So the point of the challenging case, really, I don't know if we have anybody who's I think nobody volunteering to sort of come forward and discuss it, but the interesting thing to me was the polls. So the natural history, I think we're all agreed, we're all concerned about crouch. That crouch is a one-way ticket to increasing deterioration in terms of function. And I think there's an evidence base for that. So in this particular patient, we are worried. Referring to a surgeon now, I was interested, I suppose what I was getting at was whether there is a role for orthotic management before we get on to thinking about surgical management. But in terms of what surgery can do to this patient's gait, and what about motor function, you were, as an audience, you were kind of split on both of those. 50, I think you were 40-40-20 on what surgery would do to the gait. In other words, improve it, stop it deteriorating, or make it worse. And for motor function, 60% of you thought that we're likely to see improvements. But actually, I think you can see from the presentation that I made, I mean, overall, the evidence would not be for that. The evidence would be that we might be able to change this patient, the way this patient walks, which may be a good thing for her. But in terms of giving her more improved motor function, I think that's less likely. So I guess what I was trying to get at with a patient like this, at 15, she's skeletally mature. So if we're going to deal with this patient's fixed flexion deformity, we're going to have to do the second of those two options that I mentioned for knee flexion contracture. So big surgery, the idea of doing distal femoral osteotomies bilaterally. and the idea about detaching the extensor mechanism in order to address the patella alta, which she no doubt has. So this is big surgery to undergo. In order to change gait, but not improve motor function, how do you go about making a decision on this? And this is where the problem lies with multi-level surgery for me. I think if we're going to do multi-level surgery, it's pretty clear what this patient needs. They're going to need bilateral distal femoral osteotomy, patella tendon shortening, and probably psoas lengthening at the pelvic brim. For me, not hamstring surgery, because this tends to weaken hip extension. So the hamstring length is actually, strangely, often normal in crouch gait. So that's what can be done. It's the should it be done that is the problem. And that was the essence of this challenging case, really. And I still don't know the answer to it. I guess it all depends on a discussion with the patient in terms of what their expectations are, and what their family's expectations are, and how capable the patient is of going through what is going to be a massive rehabilitation program. In fact, in this girl's case, she's really bright, very motivated. I think she would do well. But that's the sort of the issues around this challenging case. Any thoughts?
Well, I completely agree. It's just difficult, isn't it? And this is where it comes down to the MDT approach, having your physiotherapist there, having had the gait analysis before, and then seeing every patient individually, isn't it? Every patient is different with different needs. See what set some aims for the operation, and then decide what will be the best thing. But certainly, there's not a correct or wrong answer to this. I would say now, let's get Lindsay Imogen. If you don't mind to get live Lindsay Hopkinson. Let's get live Gina Farmer as well. Just volunteered, so we can have a kind of nice panel to discuss case studies from George.
Okay, shall I stop sharing my screen?
Yes, please, Gavin.
Yeah, sure.
Hi, Gina. Thanks very much for this. Hi, Lindsay.
Hi.
Right, so let's see what George has for us, and then we can trying to keep it interactive. We've got good 20 minutes. It's got loads of case studies, as you can imagine. Let's see what he comes with.
Yeah, I mean, just to sort of open up on what we've just seen, and just talking about your case as well, Gavin.
Yeah.
I mean, in terms of from sort of my perspective, in terms of not doing surgery, in terms of potentially doing like orthotics and a very intensive physiotherapy or rehabilitation program, should be really on the upper limits of that, like with the sort of knee flexion contracture and the sort of hip flexion contracture. It's going to be a really tough going. Like, they're going to be big orthotics. They're going to be really, really stiff orthotics, and they're going to be. It's probably not going to be the kind of thing that she'd be able to wear, all day, every day. It's probably going to be more the kind of thing that she wears for a lot of therapy, standing therapy, stretching therapy, and then slowly, as she improves, to try to get to where we want her to be. But it'd be a long process.
Yeah. Well, comments like that are so helpful to us as surgeons, because we don't know that sort of detail. So that really helps us colour what sort of treatment we might give. That might persuade us more down the surgical route. So yeah,
because if her range of motion improved, her AFOs would be probably not massively different, but they would be different. They'd probably be a bit more bearable for her, or at least we'd be going from sort of maybe standing therapy to doing stepping therapy, and then eventually sort of much more functional training. Really, it'd be the kind of thing where she might be in a wheelchair for school, but if we had the surgery and we had good orthotics and a good program, she might be able to use the AFOs at school to get around in a sort of walker, and that might be the goal. So it really depends on what she kind of wants to get out.
What does Lindsay think? Thanks so much, George. Yeah. Let's get a physiotherapy into the discussion. Come on.
I think just from what you were saying about it being an interdisciplinary decision, one of the key people that seems to always get left out with these ambulance CP children when we're deciding about surgery and rehab is the orthotist. I feel like orthotists need to be pulled in. George is smiling now.
Yeah.
But it's true, you know, because if a family are trying to make a decision about whether they're going to have surgery or not, part of that planning needs to be about the orthotic kind of rehab that comes into play after they've had the surgery, and how that's going to really help improve the gait after the surgeons have done their magic. And I just feel like I've hardly ever had that kind of interdisciplinary discussion where we brought the orthotist in to kind of discuss how they would help post-surgery to really, you know, push forward the rehab and hopefully improve the gait. I don't know what your thoughts are on that, but
I can say it's very embarrassing to admit that, you know, I hardly know my orthotist in Evelina, London, the past 7 years, and you know, it's embarrassing, and I should do that. But this is the whole point of this webinar series. We always discuss with Gavin. It's about finding this common language with physios. We're actually with orthotists as well, finding ways how we can improve our practice. And I will certainly take that message, and I will try to do that, because we always talk about MDT approach. And as George showed today, orthotics is an important part of the treatment. You know, we as surgeons should not be afraid of AFO spleens, because we do. We say to our patients, you know, we don't want spleens, we don't afraid, you know, it's all about a balance, isn't it? You should not be afraid of surgeries. Gavin told you today, you know, it can have good effects and all this. What does Gina think?
I agree. I really agree. I invite myself along to all the orthotic appointments I possibly can do, the orthotist appointments I can do. And I really also ask for them to write letters to paediatricians and orthopedic surgeons as well, so that they get to read the reports, because I think it's just so important. I also think that although the patient is really enthusiastic about it, I had a classic diplegic teenager go for an SDR operation, and she was just, she raised money. She had the SDR operation here in the UK, and her fundraising thing was her name followed by her new legs. And despite getting her to talk to other patients and explaining to her that she wasn't going to get new legs and it was still going to be a lot of hard work, and we did a lot of pre-surgery exercise, and in fact when she went to Bristol they said, oh, well, she zoomed through week 1, we're on week 2 already on day 2 for her rehab. She regretted having the operation herself, which is what I think you talked about in one of your other webinars, is that although and as a therapist, I would say the surgery was successful, as a patient, she regretted having it done. And I think this is what's so important for us all to think, that as everybody thinks, or the clients can think, the patients can think that these operations are...
We've got some connectivity problems there, Gina. But one thing I can say, just to bring this further, Gina is very right about what she says. SDR is a very good example of a massive surgery that requires so intensive rehabilitation for many months after to get to the preoperative state. And the same...
even with them, it's going to be years of hard work. And that's what's so hard for them. But I don't know. Sorry, my connection's poor. I don't know if you heard that.
We missed some of the bits because the connectivity was not great, but I think you passed on a very good message. We're just saying, and I would just want Gavin's comment on this. Single event multi-level surgery is fine as long as you try to make it as less aggressive as you can, if that makes any sense. Okay, so personally, I'm not a big fan of doing bilateral distal femoral extension osteotomies and tibia osteotomies, because really you put them, especially those GMFCS 3/4, you can take the mobility away completely. So instead of improving our mobility, they remain 6 weeks in the wheelchair, they don't do anything, we tell them on weight bearing, it's a bad thing. So it needs to be a balance. Would you agree, Gavin?
Yeah, 100%. It's like what we are doing as surgeons is putting a mountain in front of them of rehab. And with the right preparation, they will tackle that mountain and get over the peak. But the concern is they'll get halfway up and think, I just can't do it. And then you've done the patient no favor at all.
Yeah.
And also, preoperative rehabilitation is also very important. I think it was mentioned on the chat. So absolutely, just go for it. The more strength, those operations sometimes is like having a child with no safety belt on. You're going aggressive, with 50 miles per hour against the wall, that kind of thing. You do hip surgery, for example. That's what it feels like. So preoperative rehabilitation very quickly. Right. We've got 13 minutes left to go through one of the case studies with George. And then Gina and Lindsay are with us, so we can keep commenting, keep it interactive. Go for it, George. You can share your screen with us.
Sure. Let me just find the back where they are. So this one is one of my patients now. She used to see Sam. The reason why I sort of picked her is that we've seen her for years. So we've got about 7 years of Gait Lab data on her. Because we've been seeing her for such a long time. She's sort of the first name on the list that we've got. So she saw Sam for several years, and then she started seeing Sam and Elaine at the same time. And so we have a little 4-year-old, very cute, walking up and down with her toy in our old Gait Lab. You'll see that this is slightly different to our new Gait Lab. And I will try to slow down the video because I have to do it manually. But you can sort of see a very classic sort of like escape valgus, knees coming back, very typical gait pattern, really. Lots of lumbar lordosis, lots of arms coming up to sort of associated reactions with that. And so when we sort of see a patient like that, and I saw one this morning, we've got a few concerns for ourselves. So the first one, in terms of like long-term, not even sort of counting, although they're just as important, things like walking, like participation and as such, but trying to control the feet, trying to improve the kinematics and trying to stop any contractures from forming, because as most of us have probably seen, sort of untreated cases like these or sort of not very compliant cases can sort of lead to suddenly needing surgery. So by this point, she'd had no input other than some bits of physio. This is sort of one of the, I think it's the first time we'd ever seen her. But just, if anyone wants to just sort of talk over, that's absolutely fine. I'm just going to sort of go through, if that's all right, because I've got sort of her barefoot AFO, barefoot AFO, barefoot AFO for quite a long time now. I've got her all the way up until when I saw her not that long ago, at 11. So we've got quite.
George, why don't we ask, for example, I have to apologize. I haven't asked Lindsay. Lindsay, I know nothing from before. Gina, I haven't asked. Tell us where you walk, guys, and then maybe we can ask you what would you do for that one. I know it's a difficult one. I don't want to, if you need more information, that's fine. But if you have any suggestions, you can tell us. Gina, where do you walk?
I work down on the south coast, on the Hampshire-Sussex border, and I now work privately. I used to work for the NHS in West Sussex.
You're very experienced, obviously. We can tell. You deal with a lot of children with cerebral palsy. Lindsay, remind us, where do you work?
I work for myself at the moment privately, but I used to work at the Evelina and Chelsea and Westminster, and I worked in the Middle East as well, where Gavin is now as well.
Excellent. Right. So, Gina or Lindsay, you want to comment on this? What would you do? Is it? I mean, if it feels too rash, you don't have to comment. But I would just want to keep it a bit interactive, and then we can see what George did.
Yeah, certainly from my perspective, physio's not really going to do, this is just my opinion, physio's not really going to do that much for this child at the moment. We need to change the gait pattern. The child's obviously got bilateral recubatum happening. The knees are snapping back. Obviously, I've not got my hands on her at this stage to see if she's got any plantar flexion contractures. Certainly, as I'd expect, Georgia said that she is obviously in a valgus position. Lots of alarm bells. Worried about her as she's growing from an MSK perspective, contractures, foot deformities. Really not happy with those knees. Her arms are obviously high guard because obviously it's quite challenging because she's up on her toes. So I'd basically refer to an orthotist and go along, and I would probably follow Elaine's algorithms. Certainly needs an AFO. I'd look at the angle of basically the gastroc length to make a decision on the angle of the ankle in the AFO. Depends how much whether, again, George will probably go through all this in terms of whether you're going to fix the metatarsophalangeal joints or not. And obviously tuning the shank to vertical angle is absolutely paramount.
Lindsay,
and I think her arms,
Lindsay,
And
if
from
you
my
carry on, I think Elaine, Owen and George will offer you a job now at their institute.
and from
Yeah.
my point of view, not being Elaine Owen or George, I
Go ahead,
would
Gina.
look at it from my physio point of view, and I would get her off her feet, down onto her knees, and really work her core stability and get her referred to a good orthotist, because I would try and slow her down. So I would do lots of core work with her. I would probably get her even lying down on the floor, doing rolling. I would basically just try and get glutes and quads and get hip extensions, so get her sideways walking, on her knees, forwards, backwards, just lots of core work to try and reduce that high guard and improve that trunk stability and pelvic stability until she'd got to an orthotist, in order to, give her some sort of headway work ready for whenever she got the right orthotics, because I can't deal with the orthotics. That needs the orthotist to do with. But what I can do while she's waiting is I can get to work on that core stability and try and start slowing her down, because all she's doing is rushing around. She's using momentum just to keep herself up and going.
This is excellent, Lindsay, because you highlighted two very important, ways how to help this child. Let's see what George did.
So,
They both spoke of an orthotist, George, at this point.
I can tell. So the so this is what we did. So just to sort of clarify, because what I think I'll do is I'll do this and I'll sort of speed forward to what we did to our most current GATE videos, so you can sort of see the sort of difference. But back at this point, Billy Boots went in the UK. We hadn't discovered Hummels yet. We were still sort of figuring out what we were doing in terms of LAC, how to make our AFO sort of really good, really strong. And what we ended up doing was, some fixed AFOs, some flexible METs, with some, looking at those, this is 2015. I had just graduated, but this is Sam's. I think those toes are a bit too stiff. I don't think that, and I would just have a few questions about the sort of setup, but it was what we knew back then, sort of like show over what we've got. But as you can sort of see, she's getting her knees not hyperextended anymore. Sort of at terminal stance on the right, we've got quite a good GRF. It's going through the knees, going through the posterior of the hip. So you've gone from a very dangerous sort of potential multiple contractures forming to quite a stable, quite a healthy walking pattern, really. I'll just go back over. And these were set at 90 degrees because she had plenty of range because she was nice and young. But again, I would probably bring it down quite a lot, and you can sort of see that in her next set the year after. I believe, from what I could gather, she had quite a lot of issues with these AFOs in terms of fit. And so the difference in prescription was that she was in -10, the main difference.
So, sorry, George, -10 is the angle of the ankle.
The angle of the ankle. I should specify. You're very right. So these are now -10. So she still had plenty of range, but because of the issues that we were having, what we've tended to do with these patients is we've tended to overdo the angle to get better walking patterns, and then bring that back up as they improve.
Is that because of tone, George?
That was because of tone, yeah.
Yeah.
But look at her high guard. Her arms have come right down.
Yeah, so this is a year on.
Plantar flexion.
Yeah, so if I go back to her with these AFOs, they're still relatively up there, but she would have had these AFOs on for maybe 20 minutes by this point. They are definitely lower. But yeah, after
Yeah.
a year, you can sort of see they're much improved, much more functional, getting on really
Oh.
well.
And what's nice is that a hind foot and a midfoot will be in a beautiful position now within those splints.
Yeah.
Yeah.
And that is so important to grow a nice foot, isn't it?
It
Yeah.
really is. But her hands are also functionally useful now.
Mm.
I think a big thing that I would probably like to talk about just sort of very quickly is sort of prescription and dose. So the prescription might be the AFOs, but the dosage is just sort of important as if you were giving a sort of medication. So what I mean by that is that at this point she has to wear AFOs all the time. Sort of a bit of a spoiler for later. She only really has to wear AFOs an hour a day from now on. But she, and in the last appointment, she told me that she prefers wearing them and wants to wear them for longer because she feels that she's more functional in the AFOs than outside the AFOs.
So
And that would be
George,
something
do
that
you
we
have
change.
George, do you have a picture of her, a video of her at this age without the AFOs on?
Yeah, at that age, yes. Sorry, that should be.
Just to
maybe
see
not.
what her.
No,
what-
sorry. I seem to have lost that one in the going over. I've got there's not next sort of stage.
George, the wearing those splints unmasks the anteversion, doesn't it? Her hips. She's got an internal foot progression angle. You can see more than when she's barefoot. Would you say?
Yeah, that's quite a common thing that we
about
see.
Mm.
Yeah, that's quite a common thing we see is we'll have patients with sort of straight feet walking without AFOs, and then as soon as you put them in AFOs, they're internally rotated, and parents will get very anxious about that. And rightfully so, because suddenly it wasn't there and now it is. But what's essentially happening is instead of her going into quite a lot of escape valgus, like she was before, unfortunately I haven't got her in at that age, instead of her going into that sort of escape valgus to try to derotate the foot, we're sort of putting her foot in a better position and sort of showing the sort of femoral anteversion that's sort of going on. But this is sort of her at 7.
I always wonder, George, whether their feet turn in because of the weight of the splint in the shoes. Is that a red herring, or is that part of the?
I tend to find that that's a bit of a red herring. It's more about as the foot tries to pronate, as it tries to get into escape valgus to gain more range. You get a sort of straight foot posture, but if you check all the bones, if you check the femoral anteversion compared to the tibial torsion compared to the foot position, you'll find that the leg is internally rotated, and then the foot position is what brings the foot more centrally. So you'll see. I mean, I haven't got a coronal video of her at that stage, but you'll see that your patient's sort of knees are still internally rotated, even though their feet are straight. And when you put AFOs on, their feet will match their knees, and that is just like Lindsay was saying, it's unmasking that anteversion.
And if we got her when she was kind of first pulling up to stand and getting walking, and we'd got the right prescription on her, then hopefully her anteversion wouldn't be as severe. Do you think that splints could actually impact anteversion development? The high anteversion angles.
It tends to. It would do, probably not as much as you'd probably hope for. Typically, that tends to be sort of much later on in terms of orthotics affecting that. I'll show you the video of her. This is her most recent video of her walking without her AFOs. And I mean, the difference is quite a lot. It's quite severe in terms of what she was sort of looking like. I have got a before and after as well of her, I think, there. So, at 4 and then at 11. So we've, I know you can't really see her foot posture from that, but she's actually got a varus foot posture now, as opposed to having like a very heavy escape valgus foot posture. And I mean, Sam seems to think, and I agree, is that most of that comes down to her being in good orthotics for so long that we've almost sent her foot the other way, and that's the reason why we're sort of saying to stop using the AFOs quite so much. So sort of in the first picture of her walking, we would be telling her to use the AFOs all the time. And then sort of in the second picture, we'd be talking about using the AFOs sort of more for gait training more than anything else.
That's fantastic. That's fantastic, George. At the same time, I might be the devil's advocate here, but on Gavin's presentation, there was something about the natural history of escape valgus, of plano valgus deformities in the young age. Some of them can go into varus. It's very difficult to know. And unfortunately, we need more evidence about this. And, especially, you're doing so much work there, we could have studies where we can see exactly if you have a control group, then you can see, is this the natural history or is it the splint that does this change or the correction of the deformity. But certainly this is quite impressive results you have, especially with this young girl. And I think it was very nice to have both Gina and Lindsay in our panel today. Gavin, should we wrap up? What do you think?
Yeah, I mean, we should wrap up for reasons of time. I just want to say a massive thank you to George for explaining this stuff. I mean, when I first came across this was, mind-blowing to me, really. And I'm just mindful that we have only scratched the surface. Maybe, I know we've talked about the forum. Hopefully we can continue this discussion online when we get this forum up and running. And maybe this is something that you would like to see more or hear more about on a future occasion. If that's the case, then please do let us know, either in the chat or by email. But it's been really eye-opening stuff. Thank you so much.
Absolutely. And the idea of the forum, I just want to say to everyone now that listens to us, is not just for me and Gavin to answer questions, because, we do that through the webinar. What we want to encourage is people like Lindsay, Gina, George, and everyone else who very nicely, volunteer to come live or even, do the chatting. But you guys exchange your vast experience, with the children we treat, so we can all learn from each other. And that's the whole idea of the forum. So hopefully we're going to have more about this on our next webinar. Gavin, I think I'm going to share my screen now to share the next webinar.
Sure.
Can you see that?
We can, yeah.
Excellent. So next webinar is going to be about transition of children with cerebral palsy. I think we went quite a lot of, we covered quite a lot of topics. So the one that we have not covered, and the one that most people don't know anything about, is transition, and it's a challenging topic that most of us, including you guys, have to face in a day-to-day practice. So we're going to have. I'm very excited to have Susie Turner. Susie's. I'll tell you more about this next webinar. But Susie has a scholarship from NICE, from the National Institute of Clinical Excellence, on transition, and she will be making those national guidelines. There are some, but she will modifying them. Hopefully, after Susie finishes her work, then we will be able to offer better treatment for young adults with cerebral palsy that need surgical or conservative treatment that they don't get otherwise. So there's going to be a lot of transition on this. So I hope that you're all going to join us next Monday. Please give us your feedback about today's, otherwise, in my opinion, fantastic webinar that Gavin and George have provided for us. Thanks so much for participating, and I wish you a very good week.
Thank you very much, everyone. If you could please log out, that would be